So المرة الماضية كنا نحكي عن multiple agents نستخدمهم لعلاج السكري. قلنا الانسولين هو العلاج الفعال الافضل في حاله السكري النوع الاول اللي هو الانسولين dependent diabetes mellitus. وقلنا انه for type 2 diabetes we have other options. So other options include non-pharmacological approaches plus the addition of drugs. And the addition of drugs should be based on trials and use of minimal dose possible. قلنا this is like more pronounced بالادويه اللي they cause more side effects. Like for example metformin, if you give a high dose ممكن تدخل بالlactic acidosis side effect. So you have to reduce the dose as much as possible. The mechanisms of action of those drugs are variable. Like for example, insulin is a replacement of endogenous insulin, and it utilizes or increases utilization of glucose by variable tissues, and they will be stored in their muscles, like as muscle tissue or energy source in the muscles, or adipose tissue or glycogen in the liver. We mentioned some agents like the secretagogues. They stimulate the release of insulin. This depends on some minimal residual insulin function or reservoir موجود في البنكرياس, and this is only for type 2 diabetes. وقلنا كمان within the secretagogues في عندنا sulfonylureas. They have a longer action, so they ممكن نحكي إنه تأثيرهم they are used for type 2 diabetes, while on the other hand في some agents they stimulate the release only for a short period of time. They are consumed before food and they are used only for postprandial hyperglycemia. يعني في الحالات اللي ارتفاع السكر فيهم بصير only بعد الأكل اسمها postprandial hyperglycemia. Now قلنا كمان عن الميتفورمين أو البايجونايدز. قلنا also إنه they stimulate insulin utilization in peripheral tissue. أو insulin mediates its effect through signaling molecules. So those agents like metformin stimulate something downstream للinsulin receptor اللي هو AMPK. On the other hand, thiazolidinediones اللي احنا راح نحكي عنهم, they stimulate a molecule that is downstream to insulin, which is called PPAR. PPAR stands for peroxisome proliferator activated receptor. PPAR gamma stimulation in particular on increases insulin effect على الادipose tissue. Now, on the other hand, PPAR is not only found in adipocytes or adipose tissue. It's also available in other types of tissue, like في عندنا PPAR alpha. This is found in muscles too, and also في عندنا other tissues like GI, kidneys. They use the other isoenzymes like PPAR beta delta. So في عندنا 3 types of PPAR: PPAR gamma, adipocytes mostly, and في عندنا PPAR alpha, and we have also PPAR beta / delta. So 3 types. هلا the effects of the activation of receptor is like as follows. The molecule thiazolidinedione binds to its receptor, which is nuclear, and then the receptor translocates to or moves to its binding site. Now, the binding site of this molecule اللي هو PPAR gamma response element, or they abbreviated PPRE. Okay, peroxisome proliferator response element. يمكن previously قلنا عن الثايرويد هرمون. قلنا البايندينج سايت للثايرويد هرمون بالدي ان اي اسمه thyroid response element TRE. Okay, so response elements, they are common for nuclear receptors in general. So when PPAR gamma binds to thiazolidinedione molecule, it goes to the nucleus, binds or couples with another receptor. مر علينا قبل هيك لما الثايرويد receptor we mentioned its function. It binds to retinoid X receptor, and there the combination of a PPAR gamma and RXR they bind to the PPRE response element زي ما قلنا, and they mediate transcription of molecules necessary for insulin effects on a particular tissue. Now the effects هذولا like for example enhances lipids and glucose metabolism, enhances insulin signal transduction, and leads to effects on adipocytes and other tissues like differentiation and arrests apoptosis of those cells. Now, thiazolidine, like other drugs, it has something called pleiotropic effect. So, other than having effects on like the glucose metabolism in the fatty cells, it could have effects on other pathways or like signaling molecules. So one factor here, it's P60. P60 is one of the active subunits of a nuclear transcription factor called nuclear factor kappa B. Now, probably you don't know about nuclear factor kappa B, but it's a major driver of cancer proliferation, leukemias, lymphomas, multiple types of cancer, like multiple myeloma too. So PPAR gamma interaction with the thiazolidine dione blocks the effect of nuclear factor kappa B. So obviously it looks like a potential anti-cancer agent, in fact. Another molecule that is inhibited are CFOS and CJUN. Those are molecules also drive the proliferation and survival of cancer cells. So this is also a potential for anti-cancer effect for this drug. And also it blocks the interaction of interferon gamma response element to it, or the receptor mediators of interferon gamma signaling to the response element. So probably also immunomodulatory effects. So those drugs, they might have potential as such, like those effects. Now, أكيد في research ongoing on those things. I worked on specifically لأنه NF-kappa B is a major molecule that drives proliferation of multiple myeloma cells, and there is a drug that targets it. So I worked on Pioglitazone, which is a thiazolidine dione, as an anti-cancer agent in multiple myeloma, but it required a very high dose to mitigate its effect. So this is like a big issue, انك تعطي جرعة عالية وممكن تعمل side effects to manage a cancer. Okay. Also, on the other hand, although يعني بنفكر ان thiazolidine dione can treat cancer, but there are some reports with some agents that cumulative doses of Pioglitazone, which is an agent نذكره هلا, causes increased rates of bladder cancer, سرطان المثانة. So, as we mentioned, thiazolidines, they might act on other pathways or pathways other than PPAR. And thiazolidine diones, in fact, they have multiple effects depending on the selectivity on which PPAR. So, available thiazolidine diones, and I'm reading, do not have identical clinical effects. And new drug development will focus on defining PPAR effects and designing ligands that have selective action, much like the selective estrogen receptor modulators. So, in a group of drugs, probably this chapter is almost آخر chapter بالكتاب, but الشابتر اللي قبليه ممكن نحكي المحاضرة الجاي بيحكي عن إنه الاستروجين on certain tissues الاستروجين تأثيره مطلوب. يعني مثلا مريضة سرطان بريست كانسر، تأثير الاستروجين على خلايا البريست كانسر بتاعتها are not needed. لازم نصمم دواء يعمل بلوك للاستروجين افكت على خلايا الريسبتور تاع الاستروجين في خلايا السرطان. But on the other hand, استروجين ضروري كثير because الفيميل إذا خسرت استروجين over time بعد سن اليأس نحكي أكيد you know that she ends up with osteoporosis. So if you block estrogen بالبريست tissue in other and on other tissues ممكن نعمل osteoporosis تنخر العظام or early menopausal side effects. هلا الاستروجين له effect بقلل الانسيدنس of cardiovascular disease but also estrogen بيزيد نسبة التجلط بالدم اللي هو الدي في تي. اكيد احنا بنعرف انه الفيميلز اللي بياخذوا موانع حمل كثير مثلا بصير عندهم جلطات الرجلين زياده اللي هو الدي في تي. So researchers have developed estrogen receptor او selective estrogen receptor modulators اللي هم يسموهم SERMs, selective estrogen receptor modulators. One of them اللي هو Tamoxifen. Tamoxifen is one of the most successful drugs يعني early for hormone responsive breast cancer بتأثيراته البوزيتيف على البون but negative or suppressing breast cancer proliferation. هلا still those agents they have problems right زي ما رح نشوف. هدول بيزيدوا نسبة تجلط أو جلطات الرجلين اللي هي الدي في تي في الفيميلز. هلا clearly PPAR gamma is the one that is blocked by the parent drug. أول دواء الثيازوليدينز عملوه اسمه تروغليتازون وكان مصممينه يعمل potentiation للeffect of insulin على ال PPAR gamma اللي هو mainly موجود بالadipocytes. While on the other hand, some agents could affect PPAR alpha. In the future, they might develop some agents that work on multiple PPARs. But PPAR gamma in particular موجود في الadipocytes. هلا this figure also shows like more complex يعني changes or effects. Like in the liver مثلا decreases apolipoprotein C3 through mediation of effects on alpha, PPAR alpha, increased apolipoprotein A1, 2 through effects on alpha. On skeletal muscles also it affects alpha, increases carnitol palmitoyl transferase 1. I think you know it's a fatty acid carrier across the mitochondrial membrane involved with fatty acid oxidation processes. بالskeletal muscles through gamma receptor مثلا increases GLUT4 levels, so more entry of glucose inside fatty cells, sorry skeletal muscles. But يعني in gamma راح تشوفوا انه it's mentioned in بالكتاب انه PPAR gamma is more expressed in adipocytes, although like those are effects of gamma in the muscles, but they are nothing compared to the effect on fatty cells. So زي ما شفنا انه في effects ممكن تكون على الفاسكولار endothelium like which is this مثلا changes بالadhesion molecules, changes بالinflammation. Adhesion molecules they control which cells are recruited to the endothelial cells. So maybe this is important بالinflammatory effects as or anti-inflammatory or immunomodulator effects of PPARs. It's involved in the immune system, mainly many effects. ممكن حكينا one of the effects بيكون على nuclear factor kappa B, effects on ovaries and also effects on tumor cells. وقلنا the effect on tumor cells could be anti-cancer or it could be pro-cancer. يعني إنه it stimulates cancer proliferation. In adipocytes in particular, through PPAR gamma, the effects are promotion of glucose uptake and utilization, modulate synthesis of lipid hormones or cytokines and other proteins involved in energy regulation, and regulate adipocytes apoptosis or cell death and differentiation. In a way, it arrests apoptosis. يعني بيخلي الخلايا to proliferate more. زي ما قلنا في عندنا كان 3 drugs, 2 available in the market, thiazolidinediones. One was withdrawn from the market اللي هو troglitazone, and it was because it caused hepatic toxicity. الموجودات عندنا Pioglitazones, it's more I think انه اسمه Actus. or rosiglitazone also. There are differences between them since they have different potential to activate different PPAR alpha and gamma. كمان مرة معظم الأدوية اللي احنا بنعرفها they inhibit a molecule. But those groups of drugs يعني مثلا زي thiazolidines or metformin, they both enhance the effect of PPAR gamma or AMPK. Okay, تذكروا هاي الشغلة انه they are not inhibitors, they enhance the effect of those mediators. For pioglitazone, it has also, in addition to effects on PPAR gamma, it has effects on alpha. It is a substrate to cytochrome P450, so it is a subject to drug-drug interaction, and it could be used as a monotherapy and in combination with other drugs. Now, pioglitazone in particular, there are some reports of increased risk of bladder cancer when used like continuously. Side effects of thiazolidine diones in general, they include fluid retention and weight gain. Weight gain could be either because of deposition of glucose in the fat or because of fluid retention. Now, because of fluid retention, ممكن كمان this agent could also increase the risk of heart failure, or could be not related to fluid retention or accumulation of fluids. One of the complications of diabetes اللي هو المشاكل بالعيون أو diabetic retinopathy. So الماcular edema أو part component من retinopathy, it could be increased in incidence because of thiazolidine diones, يعني بيزيدوا نسبة إصابتها، أو إذا كانت موجودة it worsens it. Okay. وفي effect للثيازوليدين diones, it inhibits bone or disturbs bone resorption, disrupts it, وبيزيد البون degradation. Okay. أو بيعمل osteoporosis. هلا the mechanism in particular إنه thiazolidine diones could affect many hormones that affect osteoblast to osteoclastic activity. So, for example, the effect on insulin and amylin reduces osteoblastic activity, or thiazolidine's potential to lower insulin and amylin. So, يعني in particular إذا بتفكر فيها إذا thiazolidine أنت أعطيتها استجابة الجسم للإنسولين ببطل الإنسولين is needed in high levels, so levels of insulin will go down as well as amylin. في هرمون من fatty tissue that is released اسمه leptin. Its levels are also reduced, and also this will increase the osteoclastic activity اللي هو bone destroying cells, or reduces the osteoblastic cells activity اللي هما bone building cells. So this will lead to osteoporosis. Another component in the thiazolidine diones, they could inhibit an enzyme responsible for the synthesis of estrogens in like our bodies. Now, estrogens are needed in males and females. They are needed in small amounts, and they are formed from the conversion of androgens in the liver to estrogens through an enzyme called aromatase. So aromatase activity is also inhibited by thiazolidine diones. So you see like يعني the effect on leptin, maybe something يعني we didn't expect, or also the effect on aromatase. So those are potentially أشياء ممكن تحكوا عنها إنها Cleotropic effects, things that you don't predict from a drug. Despite that, في تأثيرات يعني جذابة للثيازوليدين دايونز. Like for example, في المرضى اللي بيكون في عندهم potential إنه يصير في عندهم سكري، زي سكري الحمل، اللي عندهم سكري الحمل. قلنا مش كل الحالات سكر الحمل they could be reversed to normal بعد ما تولد الفيميل. أو في condition قبل الديابيتس اسمها pre-diabetes. So they proved thiazolidine diones إنه they could reverse pre-diabetes or gestational diabetes. ممكن يعملوا also drops ل triglycerides اللي الشحوم الثلاثيه وsome slight raise of HDL and LDL. زياده ال HDL could be of benefit لانه هو سكري the good cholesterol, while on the other hand LDL is the bad cholesterol. Okay, so some effects are good, some are bad. Thiazolidinediones are contraindicated in pregnancy, the presence of heart failure, or if there are poor liver function like ALT or alanine transaminases are or alanine transaminase is more than 2.5 the normal levels. اتوقع انه you have to depend on the lab results. يعني I think انه more than 60 بيكون يعني انه it's high for ALT and AST. But although thiazolidinediones are not associated with liver injury زي ما هو كان this is what happened with troglitazone that led to its withdrawal, but although they are not associated with that, you have to start monitoring your liver function tests لما تبلش تاخذ thiazolidinediones اللي هو البايو or rosiglitazone. And if they are more than 2.5 the normal, you have to withdraw the two drugs. هلا في شغلات ممكن ما يكونوا موجودات بالشرح بس موجودات في الكتاب، فراح تشوفوا انه مثلا روزيجليتازون انسحب لفتره من السوق لمده تقريبا سنه او سنتين. السبب كان انه في زياده ريبورتس ل increased incidence of coronary heart disease cases مع المرضى اللي بيستخدموه. هلا they reviewed the evidence واكتشفوا انه this is like not يعني a significant effect compared to the control and ورجعوا للماركت يعني روزيجليتازون. So it's not يعني still it's not still withdrawn يعني it's back to the market. Previously قلنا انه في some drugs they have the potential to reduce hemoglobin A1C to some extent, okay, through inhibition of absorption or delaying the absorption of glucose from the GI tract, and those are like اللي هم الالفا glucosidase inhibitors. الالفا glucosidase inhibitors they have the potential to inhibit an enzyme complex اسمه alpha glucosidase. It is composed of saccharase, maltase, glucoamylase, and dextranase. Now, all of those, they are specialized in metabolism of a certain disaccharide or a complex saccharides. So, a saccharase, for example, is the enzyme responsible for degradation of sucrose. أكيد تعرف السكروز. وين موجود السكروز؟ table sugar اللي هو سكر الطعام اللي موجود اللي إحنا بنعرفه. في عندنا two drugs approved in the United States اللي هم الأكربوز and meglitol. Compared to each other, meglitol has 6 times more potency specifically on saccharase or sucrose metabolism. Now, both of them are capable of inhibition or slowing down the absorption of glucose. في عندنا another third drug اسمه Voglobose, and this is only available in Japan, Korea, and India. هلا قدرة الأدوية السكري to reduce أو have an anti-diabetic effect تعتمد على قدرتهم to lower hemoglobin A1C. Some agents ممكن تشوفهم they mention something about fasting blood sugar, but this is like not something important. يعني بالfollow up of a patient. Okay, أهم شيء بالfollow up of patient يعني عندك مريض سكري قرابتك أول سؤال بتسأله إنه شو السكر التراكمي بتاعه اللي هو hemoglobin A1C. Okay, so you don't ask about the fasting blood sugar. This is like the old practice. Okay. Now, alpha glucosidase inhibitors could be used as monotherapy إذا كان التارجت hemoglobin A1C أو السكر التراكمي مش بعيد كثير عن الميجرد hemoglobin A1C. ممكن تضيفه كadjuvant إذا المونوثيرابي was partially effective in reversing the effect of hyperglycemia, but يعني to يعني support another agent اللي هو adjuvant use, you could add it as an add-on therapy. Popular combination انك تحط sulfonylureas على الالفا جلوكوزايديز inhibitors. هلا في some recommendations للuse of those agents. You should use them with titration, يعني انه increase the dose, start with a low dose and increase the dose. لحتى زي ما قلنا اذا متذكرين الميتفورمين one of the mechanism of action of the metformin انه بيقلل امتصاص السكر من الجي اي تراكت، اوكي، او بيقلل الجاستريك امتينج تايم بتاعه. هلا this effect بيخلي او this effect بيخلي شويه جلوكوز بالامعاء بحيث انه البكتيريا could ferment الجلوكوز وتطلع غازات وبتعمل flatulence و GI disturbance. Now this is a side effect you expect من الميتفورمين، okay, but it is more of a side effect مع الالفا جلوكوزايديز inhibitors لانه هاي هو تاثيرهم الحقيقي اصلا. فلذلك for metformin you have to start with a low dose and titrate the dose upwards. This is the same for alpha glucosidase inhibitors. هلا to take it you have to take it just before ingesting the first portion of each meal. يعني قبل ما تاخذ الوجبه بتاعتك تاخذ حبه الالفا جلوكوزايديز انهبيتور. وزي ما قلنا بتبلش بجرعه واطيه and then you increase up the dose. اوكي. الناس اللي بيكونوا more susceptible للسايد افكتس اللي هي بتاعت الفلاتولنس and so on، الناس اللي بيكون في عندهم مشاكل بالامعاء like ulcerative colitis or inflammatory bowel diseases in general, Crohn's disease. هلا as such لحاله ما بيعملوا those agents hypoglycemia, but if you combine them with hypoglycemic agents they might potentiate the hypoglycemic agent to other agents. زي مثلا sulfonylureas, they cause hypoglycemia, but if they are adjusted to not cause hypoglycemia, الجوز بتاعتهم adjusted to not cause hypoglycemia, they will not cause hypoglycemia practically. If you add alpha glucosidase inhibitors the already established dose the sulfonylurea, you might get or end up with hypoglycemia. هلا قلنا انه في مرضى سكري مثلا ممكن تشوف واحد مرمي على الارض diabetic patient، ممكن تشم ريحه النفس بتاعه تلاقيه زي اسيتون او شيء هيك. This is like a DKA patient most likely. هلا بالعاده اذا كان conscious مثلا التريتمنت انه تعطيه source of sugar to reverse الافكت اوف شوجر. ممكن اجيب انا معلقه سكر اللي موجود عندنا بالبيت احلها بمي واشرب وياها. So this is like a potential to reverse his hypoglycemia. But we don't do that with such a patient. Why? لانه الالفا جلوكوزايديز inhibitors راح يمنعوا يعني they will inhibit sucrose degradation. Okay, لانه they are sucrase inhibitors. So this approach will not work with those agents. يعني if they are used in that patient. لازم تستخدم له monosaccharide to reverse his hypoglycemia. So this is like to treat hypoglycemia you have to use a monosaccharide or a monosugar like dextrose or glucose. زي ما قلنا انه it is contraindicated in case of patients who have inflammatory bowel disease because they could exacerbate اللي هو الكومبليكيشنز عند المريض. also اذا كان في مشاكل بالكبد او mainly الليفر لانه المسؤول عن metabolism of those agents and their accumulation، الافضل انك ما تستخدمهم في مرضى معهم liver problems لانه راح يصير لهم minimal absorption, accumulation and they might cause side effects. هلا في دراسه اسمها stop non-insulin dependent diabetes mellitus اكتشفوا انه هاي agents, they have the ability to reverse the development of new cases of type 2 diabetes. Also, they could reduce the risk of cardiovascular diseases. معناها they can reverse pre-diabetes, okay? And also reduce the complications اللي جاي من مع مرضى اللي عندهم pre-diabetes. Also, إذا كان مريض diabetes established, ممكن يقلل الريسك of cardiovascular diseases بهدول المرضى. اوكي؟ خليني اذكركم انه مرضى السكري لما يكون عندهم سكري as such بيعتبروا السكري شيء اسمه coronary heart disease equivalent. اوكي؟ فبيزيد الريسك اوف مشاكل الكارديوفاسكولار diseases or coronary artery disease. يعني ممكن يزيد مشاكل MI, angina, heart failure, stroke, and so on. قلنا انه one of the new approaches were developed based on the fact انه when food enters the stomach and then passes to the intestine responds to the food entering it by releasing something called GLP-1, or which is glucagon-like polypeptide. Now, GLP-1 has effects on the brain. It suppresses appetite center, يعني بيثبط الشهية. Also, it stimulates insulin release and suppresses glucagon release. Also, it lowers or slows down the emptying or the transportation of food from the stomach to the intestine. This is called gastric emptying time, or it increases gastric emptying time. Now, GLP-1, so it is an intestinal hormone, and also it is degraded or inhibited or broken down by DPP4 اللي هو dipeptidyl peptidase 4. فthey noticed انه in type 2 diabetic patients في عندنا lack of response or inadequate GLP-1 levels that are secreted as a response to food entry into the GI tract. So they try to restore it by administration of such drugs. وزي ما قلنا الeffects, they have effect on beta cells, insulin release, alpha cells, glucagon release, gastric emptying also, and also effect on the brain and loss of appetite. Now طبعا يعني مش عارف إذا مر عليكم في الكانابينويدز والتتراهيدروكانابينول في effects لقيوها يعني although they are recreational drugs استخدموها بالماريجوانا ومن الأشياء, but they found إنه they could have effect on appetite يعني بنشط الشهية. They could be used بالمرضى اللي هم الcancer patients to stimulate the appetite فيهم. I think إنه they also have the ability to reduce vomiting اللي هو التقيؤ اللي بيصير مع مرضى السرطان. تعرفون مرضى السرطان لما ياخذوا الكيماوي بيصير يراجعوا نسب عالي. اوكي حسب الايجنت يعني انه في عندنا agents they have high risk to induce MSs, intermediate, low or minimal. So those are يعني investigationally have potential to be an antiemetic agents. So probably ممكن نلاقي in the future GLP-1 analog with only the appetite control effect يعني enhanced in it to مثلا either suppress appetite or stimulate appetite. يعني الناس السمان ممكن يصير يستخدموه to reduce weight. هلا GLP-1 has multiple effects on brain, liver, fat cells, kidneys, blood vessels, skeletal muscles, pancreas, and the heart. And they all are يعني of benefit. يعني مثلا للpancreas, if you can see, increases new beta cell formation, reduces beta cell apoptosis, increases insulin synthesis. On skeletal muscles, increases glucose uptake. But we are يعني limited بالأشياء اللي موجودات في الكتاب, which are effects on insulin, glucagon, gastric emptying, and appetite. هلا GLP-1 as such, it has a short half-life. So what to do with that? So we know إنه when DPP4 cleaves or deactivates GLP-1, it breaks it after the second, between the second and the third amino acid. Here is the cleavage site for GLP-1. So the approach was to manipulate the GLP-1 analogs in a way to change the amino acids at position 2. So this is exenatide, and this is lexeritide. So those have a different amino acid, or like different sequence of amino acids, definitely. But in particular, at the cleavage site, there is a difference that makes them less susceptible to DPP4. Okay? في عندنا many approaches to enhance the effect of GLP-1. مثلا this approach here, they diluted with chemical adjuncts such as zinc, delays absorption at the sub-Q site. زي في agent اسمه taspoglutide. Here, covalently conjugate with large molecules such as albumin in case of albiglutide, or immunoglobulin G in case of dulaglutide, retards renal elimination. So in fact, immunoglobulin G linkage with dulaglutide, in fact, it causes its reabsorption. يعني it is reabsorbed back to the circulation after renal elimination. Okay. Here also مثلا exenatide LAR مثلا coupling with biodegradable polymer microspheres confers protection, protracted release from subcutaneous tissue. It will be slowly released into the subcutaneous tissue. وhere ultimately في عندنا liraglutide attachment of fatty acid side chains confers non-covalent albumin binding. يعني it will be carried non-covalently with high strength to albumin, and it will be lost to the kidneys and eliminated slowly. In addition to يعني this is the main change in the drug. So يعني historically they found, in fact, GLP-1, an analog, they found it in venom from like a huge lizard اسمها the Gila monster. Okay. Now Gila monster, how does it feed on other animals? بتستنى الانيمالز. Okay, it is a slow نحكي reptile من الزواحف. Okay, بتستنى الانيمالز لحد ما let's say يجوا على drinking water, and then بيروحوا بيعضوهم وبيهربوا بيتخبوا. Okay, now البايت بتاعتهم it has exendin 4, which is like GLP-1. So this will lower their glucose levels, بيدخلهم بhypoglycemia, and they will faint and collapse. هيك الانيمالز بتاثروا بالسم بتاع الجيلا مونستر. Okay. So اللي بضل انه بيطلعوا الحيوانات هاي and they feed on those يعني animals. So exendin, they found out انه structurally it is different than GLP-1 من الhuman, and it is less susceptible to DPP4. من هون اجت الفكره انه to manipulate the GLP-1 analogs to produce something susceptible to less susceptible to DPP4. والله اشوف شو اللينك هاي اصلا، انشطبت اللينك هاي. Okay. So those agents مثلا نحكي they are more or less the same يعني in effect. راح نشوف انه في common features between them. فالexenatide is based or derived from exendin 4 اللي هو موجود في Gila monster venom. Okay. Now another feature لازم تعرفوه انه زي ما قلنا to manipulate the GLP-1 system, we either manipulate the metabolism of GLP-1 through introduction of analogs. Okay, يعني بنحط analog بيختلف بالميتابوليزم of GLP-1 less sensitive للانزيم اللي هو DPP4, or we could inhibit the enzyme DPP4. So GLP-1 analog or receptor agonists, in general, they are proteins or polypeptides, and they need to be given IV. Okay, sub-Q. Okay. On the other hand, the DPP4 analogs, they are orally available. هلا another thing that لازم تعرفوا عن agents, when you compare them, you have to know the potential to lower hemoglobin A1C. Hemoglobin A1C lowering potential is a determinant factor in the potency of those agents. يعني إذا كان في عندنا hemoglobin A1C lowering effect of 0.5 only, this is not much of an effect. But إذا كان يعني مثلا 1 or 1.5, this is like a potent anti-diabetic agent. Okay? So those agents, they could have a hemoglobin A1C lowering effect up to 1.2%. Okay? The side effects between those agents, they are common. مثلا here nausea, vomiting, diarrhea, weight loss 2 to 3 kilograms ممكن تكون of advantage, antibody formation that causes either neutralization of the agent or skin or allergic reactions, with the most serious side effect اللي هو pancreatitis or necrotizing and hemorrhagic pancreatitis that could be fatal. This is like a common side effect لهدول الagents. We mentioned some agents like albiglutide has a linked albumin to it. So the linked albumin, in fact, it increases the molecular size of the agent. It makes it like less susceptible to be eliminated through the kidneys. أنا مش عارف أركز على الأغنية ولا على القراية. طيب فقلنا one of the ways to enhance the effect of the agent is to reduce its elimination. So if you link it with a large molecular size molecule like albumin, or attach a reabsorption like facilitating molecules زي immunoglobulin G4 FC portion, so you will increase its half-life of the agent. So those agents, they have variable effects on hemoglobin A1C, as we mentioned. They are available in pen formulation. They all cause pancreatitis. Frequency of administration is variable. مثلا, this agent could be administered 30 milligrams weekly by subcutaneous injection. This form, اللي هو dulaglutide, could be given as 0.75 milligrams weekly by subcutaneous injection. Okay, so it is easier to be administered, or I think this is associated with more compliance of the patients if you schedule أخذ الجرعة بتاعته. Those have in common side effects that we mentioned. There are some reports in animals in rodents, those agents could cause thyroid C cell tumors, and that's why there is a black box warning that patients who have personal or family history of some tumors like men or multiple endocrine neoplasia or medullary cancers of the thyroid, they are not to be received, they shouldn't receive those agents. هلا زي ما قلنا انه additional features of for those agents there is their ability to suppress the appetite. So this might give them an advantage, خصوصا انه معظم مرضى السكري type 2 they are obese. So this could be an advantage for those patients. And still زي ما احنا بنعرف انه دائما لما يكون في عندنا دواء جديد in the market we have to monitor for any updates about any potential side effects اللي بتصير في in this with this group of family of drugs. هلا بدي بس اذكركم انه عمركم سمعتوا عن في مراكز لرصد الاعراض الجانبيه للادويه؟ حد مر عليه شيء هيك؟ هلا في مراكز تابعه للدبليو اتش او، سمعت انه هيك يعني في اشياء في شيء اسمه فارماكو فيجيلانس. هلا فارماكو فيجيلانس اللي هو الوعي الدوائي. اوكي في عندنا centers they collect the side effects of drugs through some centers that are distributed worldwide. فواحد منهم اللي هو الفارماكو فيجيلانس كان موجود في واحد تابع لكليه الطب، but I think انه هلا في مكتب موجود في مستشفى الملك المؤسس تابع للمركز رصد الاعراض الجانبيه. مش متاكد انه still there or not, but في عندنا احنا some centers that collect, document and report back to the WHO. They report side effects of drugs that are يعني responsible to collect data about drugs بعد ما يصيرهم marketing. هلا بالنسبه للاعراض الجانبيه that are reported للدواء قبل ما يصير له marketing, those are responsibilities of phases 1, 2 and 3 studies. Okay. The other approach to increase the GLP-1 effects is through inhibition of the enzyme responsible for its metabolism. And this is done through DPP-4 inhibiting agents or inhibitors. نحكي the prefix for GLP-1 analogs is like ide or liraglutide, exenatide, lizarotide, okay, or let's say ide آخرها. هلا for dipeptidase inhibitors, let's say gliptins, okay, saxagliptin, linagliptin, sitagliptin, okay. So those agents will inhibit the metabolism of GLP-1, okay, but also we في عندنا some other agents or endogenous hormones that are their inhibition is inhibited by DPP-4. زي for example في شيء اسمه glucose dependent insulinotropic polypeptide. Okay. هلا historically we should pay attention to such things. هلا إذا متذكرين في عندنا ACE inhibitors. Okay. هلا some research previously focused on using agents that also inhibit other agents in addition to ACE مثلا enzyme. So مثلا في طلعوا group of drugs for a while سموهم super ACE inhibitors. هلا super ACE inhibitors هذولا they didn't only inhibit الACE enzyme metabolites اللي هم you know اللي هو الانجيوتنسين 1 و 2 و 3 اوكي اللي هم 1 و 2 I think بس 3 is not metabolized by ACE system, but also الايس انهبيتورز they inhibited مثلا البراديكينين ميتابوليزم. اوكي، تعرفوا ان البراديكينين ميتابوليزم انهبيشن ممكن يؤدي ل most common side effect للايس انهبيتورز اللي هو الانجيو ايديما او انجيو نيوروتيك ايديما. هلا السوبر ايس could have the potential to inhibit other factors زي شيء اسمه natriuretic peptides. في عندنا ANP, BNP, CNP, DNP. اوكي، so السوبر ايس they met failure لانه they had the potential to inhibit multiple pathways, multiple targets. In fact, they caused much of side effects compared للانالابريل. في agent كان يعني it reached phase 2 studies اسمه omapatrilat مثلا. Now this agent was withdrawn على phase 2 لانه it caused lots of side effects. هلا I think if you revisit those agents to adjust the side the dose of the drug, they might have potential in fact. المهم في عندنا sitagliptin. okay, في عندنا also saxagliptin, and also we have linagliptin and vildagliptin. Now those agents, they have variable potential to inhibit hemoglobin A1C. They are taken orally. نحكي يعني شو الأشياء الcommon between them. They cause some side effects, like مثلا, for example, let's say sitagliptin causes runny nose or nasopharyngitis, inflammation of the nasopharynx, upper respiratory tract infections, headache, hyperglycemia, especially when combined with hypoglycemic agents. Post-marketing, they have shown potential to cause pancreatitis, زي GLP-1 analogs. And the same applies to all of those agents. Their potential is variable to reduce hemoglobin A1C. In animal studies, they have noticed some observations that made like some remarks على DPP4 inhibitors. Some of them, they had the potential to cause pre-malignant changes in the pancreas that could lead to pancreatic cancer, in particular to the globular or glandular part of the pancreas, اللي هو adenocarcinoma. Although like يعني those findings were found in animal models, but they are يعني not yet reported, or they don't have significant effect. يعني as يعني you couldn't for sure interpret them as something that could happen to humans. Another class of agents اللي هم يمكن حكينا عنهم، قلنا إنه glucose in the blood could be eliminated in the kidneys. هلا الكدني أي جلوكوز تحت ال 180 ملغ بير ديسيلتر بالدم راح تعمل له ري ابزوربشن كومبليت. اوكي، هلا الناس اللي بيكون في عندهم سكر في الدم most likely انه الجلوكوز is more than 180. اوكي، so this reabsorption of glucose يعني اكيد we know الجلوكوز should be filtered بالglomerulus. So some الجلوكوز اللي موجود في الكدني tubules is reabsorbed back to the blood through sodium glucose co-transporters اللي هم ال SLGTs. In particular the isoenzyme اللي هو 2. Most of the SGLT2 transporters are found in the proximal convoluted tube. والsuffix of those agents اللي هم ال sodium glucose co-transporter inhibitors نحكي glyphosate. In fact, some references they refer to them as glyphosate. في عندنا canagliflozin, empagliflozin, and dapagliflozin. Okay, and they are variable in their effect. زي ما قلنا, their potential to reduce hemoglobin A1C potential to reduce weight, potential to مثلا canagliflozin has an additional feature over the other agents انه if you increase the dose من 100 daily, which is the standard regular dose, to 300, you lower hemoglobin A1C by an additional 0.5%. وبالعاده بنزل up to 1%. اذا بتخلي الجرعه 300 بتصير الافكت بتاعه 1.5% lowering, which is like equivalent to potent oral hypoglycemic agents. Dapagliflozin potential to reduce hemoglobin A1C is lower, 0.5 to 0.8. Potential to reduce weight is lower. Okay. Well, empagliflozin is more or less زي canagliflozin. Lower potential to reduce hemoglobin A1C and lower potential to reduce the weight. Those agents, they have side effects. So قلنا انه الهدف بتاعهم انه يقللوا اعاده امتصاص الجلوكوز المطروح من الكلى back to the blood, so you are losing glucose in the urine. معناته انه وظيفه الكلى should be intact for them to have an effect. اذا نزلت الجي اف ار عن 45 mL per minute per body surface area, those agents اللي هم الكانا and empagliflozin are contraindicated. They will not be working. They are not functional. The GFR of less than 60, okay, or more than 60 is required for dapagliflozin effect. إذا نزل ال GFR أو ال glomerular filtration rate عن 60 بالdapagliflozin, it's not working, okay? So they are contraindicated. قلنا إنه مستوى السكر في البول بيزيد كتير because of the effects of those agents. يعني بيقللوا إعادة امتصاص الجلوكوز back to the blood, بيزيد كميته في اليورين, and this is a good environment for bacteria to grow. There is an increased incidence of UTI by 8 to 9% in patients consuming gliflozins. Also, when glucose is eliminated in the urine, this attracts water, so you lose more water. Okay, so this also leads to hypertension and also intravascular volume contraction. So, this leads to hypertension in patients. في modest increase بال LDL cholesterol levels with canagliflozin, and with dapagliflozin there are significant cases of breast and bladder cancer cases, okay, compared to controls. في عندنا also amylin analogs. قلنا الامylin is a product of the alpha cells, and so beta cells. Beta cells are the cells responsible for insulin release. So amylin has some effects of benefit. They look like GLP-1 analogs. So they suppress glucagon release, especially postprandially. They delay gastric emptying, and also they have effects on the appetite center in the CNS. So amylin analog pramlintide is used as an anti-diabetic agent. It is available as a sub-Q administered pen. Okay, dose is variable in case of type 1 or type 2 diabetes, with higher doses required with type 2 diabetes. The potential to reduce hemoglobin A1C مش شايف والله. Okay, so pramlintide is one of the agents that could be used as an agent in type 1 diabetes. In type 1 diabetes, you only use insulin, okay? But pramlintide also could be used for type 1 diabetes. You should keep that in mind. هلا we know انه واحد لما يكون عنده كوليسترول عالي you could use resins اللي هم هذول مواد زي powders you swallow them بعد الاكل بقلل امتصاص الدهون. هلا those resins like colsilivam مثلا it has the potential also to absorb carbohydrates and prevent or delay the absorption like absorption of glucose. This is like one particular mechanism of action or mechanism of action of bile acid sequestrant, but an additional one is related to bile itself. We know this is the gallbladder. The gallbladder is connected to the duodenum and في عندنا bile acids or bile esters combination or bile salts combination will mediate the emulsifying effect اللي هو emulsification أو استحلاب الدهون الممتصة بالأمعاء and emulsification will make them easier to be absorbed. Okay. هلا our body has the ability to take the bile acids اللي هم موجودات في الأكل and reabsorb them and utilize them and put them back in the bile and use them for emulsification later on. هلا bile acids they are not only looping in this cycle but also bile acids have some receptors. So bile acids they have a receptor called pharmacoid or pharmacoid X receptor, and pharmacoid X receptor effects or binding to the receptor has effects that like are bad for glucose homeostasis. So this is like another mechanism of action. So if you block the cycle, you might have additional like benefit in diabetic patients. Okay. هلا الافكت تاعهم in lowering hemoglobin A1C is minimal ممكن ياثروا like by 0.5% على lowering of السكر التراكمي او الهيموجلوبين A1C. كمواد that inhibit the absorption of or disrupt the absorption of fat through binding to the bile acids, they might affect the absorption of cells or drugs that are fat soluble vitamins. مثلا في عندنا مثلا مش عارف انه موجود ولا لا في عندنا دواء اسمه cyclosporin مثلا. This is like an agent formulation, the new formulation اسمها neural مثلا. Neural is an emulsified formulation. So if you take مثلا neural اللي هو sandalune which is cyclosporin together with this agent, they could the absorption of cyclosporin could be impaired. Cyclosporin is used as an immunosuppressive agent للناس اللي بيعملوا زراعة أعضاء كلى كبد heart. So many drugs are affected by this potential to inhibit the fats يعني أو fat soluble vitamins, glyburide اللي هو الجليبينكلاميد, levothyroxine, contraceptives also. Bromocriptine has a very low potential to lower hemoglobin A1C. حتى its potential is lower than placebo. هلا في section بآخر الكتاب it's talking about like how to manage diabetes مثلا. يمكن حكينا عنهم أكثر من مرة. Type 1 diabetes, you have to pay attention لل insulin. It's main drug that is used in this condition. في عنا type 2 diabetes, you have to focus on the non-pharmacological approaches, exercise, diet. Now, if those fail or the target اللي انت بتدور عليه للهيموجلوبين A1C is far-fetched بعيد كثير عن قدرة agents to lower hemoglobin A1C, you have to use combination therapies. ما بينفع تستخدم دواء واحد. يعني زي ما قلنا مثلا في ادويه بيعملوا lowering للهيموجلوبين A1C by 1%. المريض تشخص ب 11 الهيموجلوبين A1C السكر التراكمي بتاعه. والتارجت هو عباره عن 7 او 6.5. You can't lower it يعني منطقيا you can't lower it with an agent that lowers or تحطه back to normal with an agent that lowers hemoglobin A1C 1%. لازم تستخدم combination therapy مع non-pharmacological approaches. Okay? مع exercise كمان. Always we approach a single agent therapy unless otherwise indicated. يعني إذا كان زي ما قلنا التارجت كثير. You reach maximum one, combine another agent. You reach maximum in both, combine a third agent. And if control couldn't be achieved, لازم you have to resort to bedtime insulin. Like this is the proper approach to manage prescription. هلا في مشاكل بتصير لما يكون في عندك strict glycemic control. أي واحد بتفكر إنك تنزل الكوليسترول سوري ال A1C التراكمي ل 6.5 you always face hypoglycemia. والمريض لازم ما يصير معه hypoglycemia. Why؟ لأنه إذا المريض صار معه chronically hypoglycemia بصير شيء اسمه hypoglycemic unaware. يعني معناه إنه ممكن ينزل عنده السكر وما ينتبه إنه نزل عنده السكر. أوكي؟ يعني one of the warning signs لهبوط السكر الأعراض اللي بتصير اللي هو دوخة يعني مثلا اللي هو tremors مثلا ممكن also هدول الأشياء لازم يكونوا موجودات في مريض السكري لحتى ينتبه إنه معاه هبوط سكر لحتى يأخذ مصدر سكر. أوكي؟ وإلا ممكن تصير في عنده مشاكل كثير. ف proper management of patients is very necessary. هلا يمكن we have seen one face of the coin اللي هو management of glucose. في عندنا another face of the coin اللي هو management of cardiovascular complications اللي بتصير مع الدايابيتس. So like probably you will have to study that when you study both يعني diabetes as a therapeutic يعني topic therapeutic topic. في أي سؤال عندكم؟